their social world, working, having relationships, etc. It said it was such a dramatic social difference. Now the researchers didn't conclude that the drugs were the cause. All they said is, for unknown reasons, that living, listen to this, living in a developed country is, quote, a strong predictor that a person will never fully recover. That's an absolutely damning conclusion for our drug-based form of care. And I believe this body of evidence shows you why. Because our evidence tells you you're causing physiological changes that increase the risk of psychosis, the very thing you're trying to treat. Now, there was another study done by the University of Pennsylvania, again, that I think is so powerful, so damning. And again, I want to emphasize, I come from not an ideological point of view. I just want to see what the evidence is. And it's an MRI study that followed patients newly diagnosed over an 18-month period. And here's what they found, given neuroleptics. They found that over that 18-month period, they could see a drug-induced enlargement of the basal ganglia. They could see it related to drug dosage. So now we see a change in the brain. Then they tied that, and by the way, they're not doing this to question the merits of neuroleptics. They're actually looking to see, I guess, morphological changes in the brain due to the disorder. But what they find is it's linked to the drug, and it's linked to the dosage. But here's the thing, and of course this didn't get publicized at all, is that they found, and I quote, that this enlargement of the basal ganglia is associated with greater severity of both negative and positive symptoms. So think about how clean this study is in a way. You bring in an agent that causes an abnormality, it blocks dopamine function. In response, you see this abnormal change in an area of the brain, basal ganglia. And finally, that is associated with a worsening of the symptoms the drugs are supposed to treat. Now, that's a sign of a failed form of care, but it also fits with this whole data I'm talking about, chronicity. That's what they found. You were making people more vulnerable to psychosis. So, and then I'm going to go quickly to see if we see in some other areas some of this same paradigm, short-term relief, long-term chronicity. But if we were to talk honestly about drugs for the use in schizophrenia, here's what I believe we would say if we were talking scientifically. We would say, of course, we don't know what causes schizophrenia biologically. And by the way, Science magazine, I think it's January 13th, 2002, all the bigwigs confess that. We have no idea, okay? So we have no evidence for a chemical abnormality. But what do the drugs do? They create, this is sometimes I think that's missing. Sometimes you hear people say, you know, there's no evidence of a biological abnormality for mental disorders. True. However, once people are drug treated, they have an abnormality. No question about it. Their dopamine systems are no longer working in a normal functional manner. So you're creating an abnormality, and in return, you cause physiological changes in the brain to compensate for that. And so you end up with a brain that, in fact, is no longer normal. That's true once they get on that. And so what do we see in terms of the outcomes? We see all sorts of, and it's not really right to call them side effects, Parkinson's, akathisia, etc., tardive dyskinesia. In essence, that's the direct result of creating this abnormality. And then the only thing you could say is, maybe, however, this change does diminish psychosis. And yeah, it may over a short term. But we don't have good evidence that it does it over the long term. And so literally, in my opinion, you have outside agent comes in, causes an abnormality. It's a disease-causing form of care, basically. Scientifically, that's what you see. You see changes in the brain, changes in neurotransmitter function that are abnormal. And by the way, lest you think this is radical, Steve Hyman, who's the former head of the NIMH, a neuroscientist, here's what he describes how psychiatric drugs work. He says, he talks about this, how they all change, you know, they either dampen down neurotransmitter activity or they try to increase neurotransmitter activity. And he says, if I can find this, Here it is. His words. He says, by the end of a few weeks, the patient's brain is functioning in a manner that is, quote, qualitatively as well as quantitatively different from the normal state. Mainstream psychiatrists saying we are creating abnormal states. Now, if you're creating abnormal states, that's a very potentially dangerous thing to do, because we know that other diseases that cause sort of abnormal states in the brain have real problems over a long term. Now let's go to antidepressants. I think I have time to run through that brief history real quickly to see, just to sum up on the schizophrenia. So where are we seeing the increased disability? My belief is if we treated people initially with placebo, but in a structured environment, you would see, everything tells us that 50% or more basically would get beyond their psychotic break and get on with their lives and not relapse. But one of the reasons I think we're seeing this increased disability, today we take those people, we put them on a cocktail of drugs, and basically now they're stuck. They're stuck in chronic illness. I think that's what the evidence shows. Anyway, history of, and again, I think the evidence all comes together because you have the supporting evidence of increased chronicity. History of antidepressants, real quickly. They, of course, come on in the 60s, early 60s. At that time, by the way, drug companies don't want to even bring a drug to market because they don't think there's a big enough market for depression. Just not enough people who are depressed. Amazing today, of course, that we have the amount of spending we do. But anyway, here's the first key thing on antidepressants. There were, again, over the short term in the early studies, you would see a net benefit over placebo. It would be 10, 15% of significant reduction of symptoms over a 6-week period. Not great, but some. But then researchers came up with a very interesting question. Was it basically just because the antidepressant caused a little bit of biological effect that you had basically an enhancement of the placebo effect with the drug? So they did trials. There were 8 such studies where they tested the drug versus an active placebo. An active placebo is a drug that might cause dry mouth but isn't meant to treat depression, etc. It's just something that causes a little biological effect that makes you think you're getting the magic pill. In those studies, the difference in reduction of symptoms over 6 weeks disappeared, which raises a question of if we even have an antidepressant, but it disappeared. Now, the big study that was done to look at long-term outcomes in depression was done in the 1980s. The NIMH Collaborative Depression Research Study had 4 arms, 2 psychotherapy arms, it had a drug-treated arm, and basically a placebo arm. Now, at the end of 6 weeks, there was no difference in outcomes in any of the 4 arms. All the same. Now, researchers were sort of stung by that, and they did some further data analysis, and they said, well, maybe we can see some benefit in the drug-treated group in the severely depressed. And that's how they sort of rescued the drugs at that time. But then they did an 18-month follow-up study to see who stayed well during that time. And at that point, we began to get some separation in the 4 groups. The stay-well rates were highest for the psychotherapy groups and lowest for the drug-treated group. Again, the question is there something about that exposure to drug that in fact is making you more vulnerable to the target symptom than you would be otherwise? And then research, and by the way, the stay-well rates were terrible. For the psychotherapy arms, it was about 30%. For the drug-treated arm, it was 19% during the 18-month follow-up period. And then researchers went back and looked also when they started analyzing dropouts. And here's what they concluded. That if you include dropouts in the analysis, the results for the drug-treated patients look even worse. Patients receiving the antidepressant were most likely to seek treatment following termination of the treatment period, produced the highest probability of relapse, and exhibited the fewest weeks of reduced or minimal symptoms during the follow-up period. Same sort of paradigm in that you might get a slight benefit in the whole over a 6-week period, but over an 18-month period, you did not see, even on the target symptom, a benefit. And once that happens, at least as a rationale for using the drugs as just a first response to depression, it disappears. Now again, maybe you can find a response that when other forms don't work, you want to use them. But as an immediate response, it disappears because you have this long-term problem. Now an Italian doctor by the name of Giovanni Favi, he wrote in and said, wow, it appears that the drugs, quote, worsen the progression of the disease in the long term by increasing the biological vulnerability to depression. That was his